I make sure I get everything.
I'm gonna go warm up my food. Like a baby. Yeah. Huh? Oh, that bacon. Oh. Yeah, there's one in the kitchen. No, there's one by the printer.
I wonder how I got this to work last There. Okay. Okay, can you see me?
Yep.
And you can see the PowerPoint?
Yep.
Okay. All right, so this is the attendance, so please sign in. Okay. Today we're going to be talking about admission guidelines, intoxication and withdrawal symptoms, and co-occurring disorders, and how that all relates. I'm the Senior Director of Treatment Services at Wayside Recovery Center. My name is Finn. We're going to talk about the admission and service initiation criteria for Wayside Recovery Center, and we're going to talk about intoxication withdrawal symptoms and how to assess those, and learn criteria for determining when medical detoxification may be necessary. So CFR Title 45 indicates that we have to give preferential treatment to pregnant injecting drug users, and then pregnant substance users, injecting drug users, and then all others. So if the way that works is if we have a wait list, and if we had somebody who's an injecting drug user on the wait list and they've been on it for a week, but then we had somebody who's pregnant and injecting drug user, they would actually admit before the injecting drug user when there's an open, because they'll have preferential treatment placement. We have a non-discrimination policy at Wayside, so we don't discriminate regarding age, sex, race, national origin, religion, sexual orientation, or disability when we're looking at admission criteria and who can admit to our program. In order to come to Wayside, you do have to be 18 years or older. We have had an exception where we've had a variance for somebody who was no longer in school, 17 and pregnant, and needed like family treatment. So they would not have been able to be accommodated in an adolescent treatment program because they needed a place to be able to give birth and receive pre and postnatal treatment. But that would require a variance with DHS. Admission criteria is 18 years or older. They also need to have a diagnosis of substance use disorder in accordance with the DSM-5, and then a willingness to participate, as well as a physical and mental capability to participate, and then an ability to obtain funding. So we do have centralized intake, and that is located over at Wellness. And so when they receive a Rule 25 and a referral for our program, some of the things that they're looking at in order to make a decision on whether the person can admit is that the individual's needs are appropriate for the level of intensity and the types of restrictions we have in our program. That treatment services could reasonably assume to be appropriately provided by our clinical team. And then we reserve the right to refuse admission when the clinical staff determine that Wayside would not provide an appropriate recovery environment or be unable to meet the client's need for specialized services. And so something like this that has come up before is we've had clients try to admit to the family treatment program, but like their child has a feeding tube and they can't separate from their child, and that is something that we're not able to address as a clinical team because of the specialty service the kiddo needs and the fact that the mom cannot come to treatment without her child, which is why she's looking for family treatment. So that's something that we think about. The retention of the program is evaluated on an ongoing basis for clients who are marginally appropriate. So the way we see that is sometimes when we have a client who maybe have a lot of medical or physical needs that we're going to give it a shot because they're sort of on that border of whether or not we can provide the care. And in that case, we really want to let the client know that they're coming in and we're going to be assessing as we move forward that they're able to participate in treatment and appropriately get their needs met. And if we determine that they're not, we're going to try to transfer them to that appropriate level of care. And then that the need for their mental health and chemical dependency services is within the range of a non-medical facility. So some clients who are clearly not appropriate for admission are those who need emergency medical services or detoxification. And so that first one is what I want to spend a large part of today talking about, which is how to determine when a client needs detoxification services so we're not admitting clients who do need that. If they have a substantial likelihood of physically harming self or others, or persons whose presence in the program could pose a threat or danger to the safety of other clients. So some things to consider there is a client who's actively suicidal with a plan. We'd want to be calling 911 and have them taken to like acute psychiatric. They would not be appropriate to admit here because of the substantial likelihood due to their suicidal ideation with plan and intent to physically harm themselves. Clients who are reporting a homicidal ideation with plan and intent would also not be appropriate. Clients who are unable to make a commitment to the program. So oftentimes, clients, when we're talking about number 3, sort of self-select themselves out of the process, like, I don't know if I want to be here, I'll give it a try. And once we set those boundaries in place, like we just had a client of probably about 40 minutes ago, did not attend programming yesterday, when she admitted did not attend programming today. When we set the boundary of you have to attend programming in order to remain here, she went ahead and self-selected herself out of our program and is leaving against staff advice because she's not able or willing to commit to the program and what she needs to do while she's here. So generally, number 3, that's sort of client-led. They'll kind of inform us when they're not wanting to make a commitment. Inability to meet the admission criteria that I had just talked about prior. Individuals that have a family or personal relationship with Wayside employees that may negatively impact their treatment due to boundary or ethical considerations. So, if you're doing in the middle of an admit and a staff comes to you and asks you to step out, and they say, you know what, we have a employee in my department who says that they're actually cousins with this client, that might be a reason that we're not able to move forward with the admission. Another part of this that I'm going to add to the actual policy is if there's a substantial relationship with another client that we find out for example, they find out that their partner is here or like their sister is here, that would be a substantial family or personal relationship that, because of the nature of the way our programming is run, we wouldn't be able to keep that client here. So we would not admit them then in those types of dual relationship situations. Persons having or suspected of having a communicable disease or disease that would endanger the health of others. So things like that we get concerns about that we probably wouldn't want to admit a client with is certain types of influenza, things that are highly communicable. We wouldn't want to admit a client with that. We end up sometimes having clients who are living here that have certain strains of things like influenza that we work with when they're on antibiotics We do have our quarantine procedure, but if we can help not exposing clients and working with centralized intakes, and maybe the client readmits after they're stable and no longer, if the virus no longer communicable, that it would endanger the health of others. And this is something we talk about a lot at family because of the young children, especially the infants who have immune disorders, that we really want to make sure that we're not admitting individuals who have a communicable disease that could really harm or impact those who have immune systems that are compromised. Persons that are not able to care for themselves, and persons who require intensive nursing and medical care. The nursing department is usually pretty good at letting us know right away, but sometimes we kind of find it out a little after the fact of admission. But if we do find it out during the admission process, that's another reason why we'd want to halt the admission and indicate that this person's not appropriate to admit. I'm sorry about the dinging that's happening with my computer, but in order to be able to hear what's going on, I have to have my sound on. So, okay, so let's focus on that first one, which is need for emergency medical services or detoxification. So one of the reasons why we would look at a client going to detox and not admitting to our program during the admission process is if they are currently intoxicated. So some of the things that you might notice, like if, for example, with marijuana, if they're currently intoxicated, particularly if they're having high doses, is they're experiencing active psychosis, delusions, or hallucinations. Those are the ones probably with marijuana where we're saying that they need to probably go to detox or get some acute psychiatric services or address that prior to admission. If this is drug-induced. Altered senses, altered sense of time, change in mood. I know that oftentimes detox say, well, we won't detox somebody on marijuana. And so that's why I'm saying when it's getting to the extent where they're saying, no, this is the marijuana that's causing me to experience this level of psychosis, delusion, hallucination, they aren't appropriate to admit. So where can we send them, like acute psychiatric services then, to stabilize them so that they're no longer experiencing those symptoms prior to admission, because they are self-reporting as drug-induced and not related to some sort of psychiatric situation that they're familiar with, so like major depression with psychosis or schizophrenia. Cocaine and crack, oftentimes you're going to see them, everything's going to be stimulated, dilated pupils, inability to sleep, very pressured, rapid speech, a lot of excitement, restlessness, irritability, and anxiety. Again, this is a situation where we don't want clients being admitted and then high in our program, and this is oftentimes with amphetamines, it's difficult to know, is this how the client shows up? And so sometimes a client will self-report, I smoked crack in the parking lot before I came in. We know that it has a rapid onset, but then also a short duration. And so this is something, can we work with centralized intake to perhaps have the client admit later today, later on in the day, or even tomorrow, so that they're not coming in high. And then we can certainly give them the referral for detox, and most likely, because it's an amphetamine, detox will not take them. And so then it's like, where can they safely go to come down, just so we're not admitting them high in our community. And so that they're not then triggering the other community members by being high. And I know that this is a hard one, so oftentimes this is only, they're going to be self-disclosing because we just are meeting the client and we don't know, for example, like, is this ADHD? They just show up fidgety and difficulty paying attention and maybe some rapid speech. And so certainly I don't want everybody who's fidgety and anxious and irritated, I don't want to say, oh, you can't admit today. So this would be more of like, the client is self-disclosing, no, I am currently high on crack that I just did out in your parking lot, I wouldn't really want them in our community high. And so we'd be assessing that and working with central intake to figure out a good situation for that person to be safe, but also keeping our community safe as well. Heroin and other opiates, the biggest one I think you'll notice is the nodding out that happens, which is the back and forth state of being conscious and semi-conscious. I think that's probably the indication as a clinician that you're looking at opiates and not something else in terms of the symptomology. There is a major concern that if client comes in intoxicated with opiates, depending on how much, there could be a major concern of the possibility of overdose. Everybody who works for Wayside receives Narcan training, and we do have some on site. If you're concerned, if the client is nodding out and then becomes non-responsive, you want to call 911 and then do Narcan protocol. The 911 operator will likely walk you through that if there's concern that the client is inactive overdose and needing that. But if a client is currently intoxicated from opiates, that's one that absolutely detox will accept for opiates. So if they're currently intoxicated, that's again not admitting them, talking to centralized intake, getting them to a detox bed so they can get comfort care, and then come back and admit to Wayside when they're no longer intoxicated. Methamphetamine, that's another amphetamine similar to what you'll see with cocaine and crack. And so again, that's a hard one to be able to put your finger on if that's active intoxication. And so often the only way we really know for sure, because we're just meeting the client, is often that they're just self-disclosing I'm high. And that's so another situation of working with central intake that can the client admit later on in the day, because it's a rapid onset and then the duration is shorter for the amphetamines. And the client can go somewhere safe while that happens. They come down. Can they go to detox, or do they need some other type of service as well? So that would be looking at admission and current intoxication. I want to talk about, I think, where the majority of our clients fall, because generally, they might use in the morning, but most of our clients don't come in currently intoxicated. However, a lot of our clients come in active withdrawal, which those are uncomfortable physical and mental changes that happen because our clients have been physiologically dependent on alcohol and drugs. Clients, the symptoms they have are going to be variable to themselves, and that's going to be determined by their body type, the drug type, the quantity of how much they've been using, the frequency of that use, and the route of the drug. So for example, an individual who uses alcohol 1 liter a day for 1 year is going to experience longer and more painful withdrawal than an individual who uses cocaine 3 times a week. So it's important to know that withdrawal symptoms are uncomfortable for clients. So if they're a little cranky, it's often because they're a bit uncomfortable. Some substances can cause dangerous and sometimes life-threatening symptoms, and it's up to us to be able to assess when that it is becoming dangerous or life-threatening and additional care is needed. We want to provide client education on what withdrawal looks like, ability to provide their correct level of care, be able to validate that the client's experiences are real and it is uncomfortable, and then we want to, of course, partner with the client in order to prevent relapse, because one of the riskier times is when they're actively in withdrawal and experiencing very intense cravings. And that's doing all of those things when we're looking at assessing and navigating withdrawal symptoms can increase overall success for the client. So some non-specific symptoms that are general that people can experience regardless of their substance abuse is things like anxiety, restlessness, irritability, difficulty sleeping, headaches, poor concentration, some depression, depressive symptoms, and socially isolating themselves. We have the physical symptoms that can include sweating, racing heart, palpitations, muscle tension, some chest tightness, difficulty breathing, possible tremors, and then overall just having like flu-like symptoms like vomiting, diarrhea, nausea. So these are non-specific and can really occur with almost any substance. And so it's important to let clients know that that's normal and they are uncomfortable. And then it would make sense that they're really sort of irritable and cranky, because if you look at that list, many of us, if we were experiencing any of these, would likely call into work, and they have to be in a residential setting, depending on what the site they're at, with maybe 41 other women or 35 other bodies, or sitting in groups in small rooms feeling this way, which is, building our compassion and empathy for that's important. So alcohol withdrawal is one of those drugs that can be dangerous and sometimes life-threatening. It's important to know that alcohol withdrawal can kind of develop pretty rapidly after your last drink, 6 to 24 hours after the last drink, in fact. It usually peaks, and this is true for most substances, after about 3 days. So in this case, after about 2 days. In this case, it usually peaks after 36 hours and then goes on to diminish in 1 to 2 days. So generally, it's what I meant when I initially said 3 days, it's probably fair to say for most substances, letting the client know that after 3 days, after that 72 hours, they're probably over the worst of it for most substances. So because we know that for most, it's going to peak at 36, that it's pretty fair to just say you made it, you're 72, you're probably through the worst of the withdrawal. But things that you want to be really concerned with, and definitely look at stopping admission, is if they disclose a history of seizures or DTs, or what we call delirium tremens. In those cases, if they have a history of that in withdrawal, they're much more likely to experience it again. And so those are individuals that absolutely need detox services. So we'd want to, if they disclose that to us, we'd want to stop our admission process and make sure we can get them to a detox bed. Other things that can happen is frequent sleep disturbances or nightmares. Also, sweating, tremors, pulse over 100. Those are common things that we see with alcohol withdrawal. So the elevated blood pressure, if it gets obviously too high, we have our blood pressure protocols that the RAs follow so that the client gets medical care. But at any time, if the client's experiencing disorientation, paranoid delusions, visual, auditory hallucinations, we absolutely want to be calling 911 and getting them to a detox bed, including if they have a seizure, stroke, or heart attack. We want to obviously call 911. Ideally with alcohol, if they've been consuming large quantities of alcohol on a daily basis, and they don't know, or they haven't stopped drinking to know what withdrawal, it just for their own comfort, encouraging them to go to detox, and at a certain point thinking to yourself, should I require this, rather than admit the person. And I know that centralized intake, that's something they talk about with alcohol withdrawal too with the client as they're trying to assess it. And because they made it to this point, don't assume that they're clear. It is still your responsibility as a clinician to be assessing whether or not the person should probably go to detox and come from detox back to us for alcohol withdrawal. Often detox and medical services use this assessment. This is usually done by a nurse. You have to be trained to use this assessment. But these are similar things to what we want to ask them when we're assessing alcohol withdrawal, such as, are you experiencing nausea and vomiting? Are you experiencing tremors? Are you having any visual disturbances, chest pain? So similar things we still want to ask them as clinicians to see when we're doing the first dimension assessment to see how they're being impacted by the withdrawal and if it's something that is going to interfere with their ability to receive treatment services safely, so we can go ahead and get them to detox. So again, this is something used by nurses and doctors. So a case example that I want you guys to discuss is regarding Mr. A. So if you're on your own watching this training, just read through it and think through what and where and if you would admit this client or if you would refer them to detox. And if you're currently with me, maybe you guys could get together and kind of consult with each other around whether or not this case, Mr. A, is somebody that you would go through and admit, or you'd be referring to a different level of care, or what your steps would be.
Because he's been getting for the bags and not to mention his blood pressure just makes me afraid that he could have like a heart attack or something. Like I want this. Yeah, he's only a mild withdrawal. He's something like 2 hours ago. Yeah, because it says 5 to 6 drinks, which I assume is hard liquor. Like, are they drinks? They're probably nice pint glass. You got a bar that goes through the treats and special.
Okay, so let's talk a little bit about Mr. A. So we know that he already has hypertension issues, and we know that because alcohol is a sedative drug, unfortunately, when you withdraw, it creates an increase in blood pressure. So this gentleman already has hypertension issues, probably outlined in dimension 2, and then we're looking at assessing dimension 1. His current blood pressure reading is only 2 hours since his last drink, and insufficient time has elapsed for the full withdrawal syndrome to develop. So his current blood pressure was already high, and because it's only been 2 hours since his last drink, we are then expecting it to definitely increase, right? So unfortunately, both for dimension 1 and dimension 2 now. So we're looking at can he admit according to the matrix? Well, you're going to have a higher rating in dimension 1 now, likely than high and medium intensity residential treatment can accommodate. And now also we're having complications in dimension 2 medical, and this person probably requiring medical care. So because of the high severity resulting from the interaction between dimension 1 and 2, we would want to say that he should be treated in a medically monitored inpatient withdrawal management service. And so we don't really have ambulatory withdrawal management with extended on-site monitoring in the state of Minnesota, but it's certainly something that ASAM says could be an alternative if he was appropriate for it. So this would be an individual that you would want to refer to treatment and not admit.
So would you call the ambulance in this case?
It depends. If he couldn't safely get to detox, or I don't know how much he has been drinking or how much higher, and if he's intoxicated currently still or considerably drunk. Yeah, I mean, you could certainly call 911 and have him taken to detox. Some clients are fairly sober at this state, and our staff could drive them, or
Can you repeat the question just for the recording? I can't hear it.
Sorry. Rebecca asked if we should call an ambulance for this individual.
Okay, thank you.
So alcohol can be dangerous and life-threatening, and so can withdrawal from benzodiazepines. So this is another situation where generally you need to be medically monitored if you've been using high amounts of benzodiazepines and receive a taper. Benzos and alcohol can cause grand mal seizures, heart attacks, strokes, hallucinations, and DTs. And again, just to reiterate, if they've had a past experience with this, they're much more likely to experience it again. And so letting clients know, sometimes they don't want to be honest because they know they'll have to go to detox, but letting them know and educating them that there could be huge medical risk if they're not honest about the previous symptoms they've had for withdrawal, and you're just trying to assess where their appropriateness is and whether or not they need medical or comfort care. So with stimulants, these are things that generally they can withdraw fine from in residential treatment, but you're not generally going to see a lot of complications. One of the exceptions to this is those that crash for multiple days at a time, meaning they're like sleeping and they're having a real difficult time getting out of bed. In this case, it's assessing can they appropriately participate in treatment because they're not getting out of bed because they're sleeping for huge long stretches at a time. And in being able to assess, is it lack of motivation? Is it some sort of mental health like depressive symptoms? Or is this withdrawal from, like a binge of like 5-day use of amphetamines that's kind of causing them to crash? So, but we know that anything that's interfering with treatment is something that we're going to want to not wait on or just make assumptions, that we're going to want to do a lot of assessment to clearly figure out what's happening to that person. And that's likely something we're going to see once they're already admitted and not in the middle of the admission process. Opiates, although seldom life-threatening, are incredibly painful and hard to tolerate with withdrawal and high likelihood of relapse during experiencing withdrawal. And so oftentimes clients who've been using opiates ongoing, encouraging them to utilize detox services and comfort care if they need it, just to help with their overall success. Complications with withdrawal for opiates are things like dehydration because of the excessive vomiting and diarrhea, not anything that it's to the extent with alcohol and benzos, or we're talking about seizures and like these real life-threatening heart attacks and things like that that we're really worried about. But withdrawing from opiates can be quite difficult and uncomfortable, and so encouraging them to seek that comfort to just make residential treatment more successful for them as well. Since they're at high risk of leaving ASA or AWOL if they're experiencing huge amounts of cravings, along with all of the real uncomfortable physical sickness that they're experiencing, like diarrhea, drug seeking, and insomnia, things like that. So when you're doing the admission process and you have a client who knows themselves, they know what their body does when they withdraw from the amount of opiates they're on, letting them know will hold their bed and they can still seek detox services, right? And that they can get comfort care in detox to help with the aches and help with the flu-like symptoms and increase overall success, and giving them that option before they fully admit to treatment. So kind of what I said, which is to make sure you're offering detox as an option to clients who appear to be struggling with their symptoms and that who are disclosing those symptoms to you. It's absolutely okay for them to go to detox, and we want to encourage it as part of that to continue care. remember that alcohol and benzos are the ones that we really want to be careful with assessing, and the necessity to possibly go to detox. And that if they've had a previous history of these symptoms that can be life-threatening, that's just an automatic, let's get them to detox. So seizures, DTs, those types of things. And then heroin and opiates, although not usually life-threatening, that there's a high risk of relapse, which of course for those who are on opiates and heroin, relapse could also mean loss of life due to hypoxia. So we really want to look at providing them the opportunity to go to detox and receive comfort care to help them be more successful. As always, I want you guys to feel free to contact me if you have questions about intoxication, withdrawal, how to assess dimension 1, and as it relates to the other dimensions as well, because things that can be happening with them at admitted dimension 1 can impact all their other dimensions as well. And so that's going to, when we're looking at their appropriateness to admit, or if they are admitted and you're starting to notice these symptoms, they may need a different level of care for a short period of time in order to stabilize related to the symptoms they're experiencing with withdrawal. Do you guys, or does anyone have any additional questions for me? Okay.
So with like methamphetamine withdrawal, so typically like you've stated, people come in to be very fatigued, and it's very hard or difficult to motivate them to get out of bed. Now, it's difficult to tell if it is in fact the drug or mental health symptom or something else going on. Typically, though, they can articulate like this is kind of a pattern where I'll binge for 5 days and then like out for 3 days. How do we effectively address that and treat them as like, you know, like going and speaking with them and trying different motivation strategies to get them in group enough? Because I know being in group is also very important. I mean, are they self-selecting themselves if they're able to get, they're unwilling to get out of that and join a group?
Yeah, so when they're that exhausted, where they are, so the question is about clients who are in amphetamine withdrawal and have kind of crashed and are having a real difficult time to get out of the bed, assessing are they unwilling or unable, and how to sort of assess and help them be successful. And so the client is able, because they're getting up and going to the bathroom, to walk down a hallway and sit in a chair. The question is, can they commit to doing that minimally? You know what I mean? And so how can we help support them? So if they're getting up and they're going to a meal, or they're getting up and they're walking the steps to get to the bathroom, can they get up and walk and take the steps to get in a chair? And I think that's where, as group facilitators too, those clients who are really struggling to stay awake, that is important for us as a multidisciplinary team to say, like, this client's withdrawal history is to like crash and be out for a couple days. And so this is success for her to be in group and sort of have her head down even, and really having a difficult time, and making it very clear to the client, you're doing the best you can, and we're going to look for improvement over the next couple days as you, the substance leaves your system, and the worst of it, again, being that 48-hour period. And so we should be seeing an increase in participation while they're in the room with us, particularly on that 3rd day. And they just don't have an option to just lay in bed for those 3 days. So we still need to have conversations of, there's a reason you're here, you want to be here, you want to do this. So can you get to the bathroom? Can you walk down the hall and and sit in a chair and get to group? You can bring a blanket, you can make your chair comfortable, but you need to be in group. And because they're there, they might, for the first day or two, get 40% of the content, because they're kind of in and out of a wake state, you know. And also assessing, is this something more? Is this also a medical issue or a mental health issue? Generally, the client's the expert on them, and they're like, nope, this is just what happened. I binged for 5 days without any sleep, and now my body's exhausted, and I'm exhausted, and I'm having a hard time staying awake. I really just want to go to bed and lay in bed for 3 days. And that's not the option, but they can sort of lounge around in a chair during group for 3 days. Did I answer your question at all?
Yeah, that's helpful. Yeah, I just know that sometimes people will find that to be disruptive and different things like that. So I guess it's just important to know that we can provide that option to them and just communicate that to the rest of the staff.
Yeah, I mean, I think that's why I wanted to do this training, because I think that we need to also help educate. Remember that first part about client education? We need to help educate the other clients as well as the client who's experiencing the symptoms. You know, sometimes we make assumptions that a client who keeps getting up to go to the bathroom is doing something other. And if they have extreme diarrhea, it's likely they're getting up 4 or 5 times to go to the bathroom. And that is disruptive to others and also embarrassing, and if they have to say something. And so how can we pull the client aside after group and, you know, say what's going on? Do you need to drink lots of water? Are you needing any medical care? And how can I help build compassion between you and the community? And also, is it okay if I let the other staff know what's going on for you? There's an assumption made why she's popped up and left to gone to the bathroom a bunch of times. So I think there's a lot of symptoms that we see, even like extreme irritability. I mean, they're really sick, they're not feeling good, often their first 3 to 4 days here. And, you know, and again, looking at those general symptoms, that's true with any substance. They're just not feeling good after sometimes years of daily use of whatever their substances, and now their body is without. And so they're absolutely going to be irritable, just like any of us would be if we were expected to still come to work feeling like that. You'd just be shorter. You would have less attention span. So there'd be a lot of things that you would see that's not personal to the person. And so sometimes we unfortunately make assumptions that this is somehow indicating the client is less motivated or they have poor interpersonal skills, when really this is a very normal reaction to having this extreme withdrawal. And if it's getting to the point where it is interfering with their ability to receive treatment, then we have to be able to pivot and make an assessment that maybe they do need to go to detox, maybe they need medical care. Like, for example, if it's diarrhea that's not stopping, or they need maybe to get some sort of medication to help with the diarrhea, or the vomiting, if they're saying that they're extremely nauseous and having a hard time staying in group. Headaches is another issue, if they're not able to be in group, and, you know, making sure they get medical care as well. Any other questions?
Has Wayside ever thought about opening a little detox part?
The question is, has Wayside ever thought about opening up a little detox part? So I worked for a couple years in a detox facility as a counselor, and I think that it's its own area of expertise, and that would require us to have a medical director and get trained and have a different area of expertise than we're currently in. So maybe it's someday, right, when we take over the world, but, well, that's on record for forever, huh? I'm being recorded.
But not today.
What?
But not today.
Not today. We're not taking over the world today. Yeah.
We're not opening a detox today.
We're not opening a detox today. Okay. Any other questions? No? Okay, well, thank you very much for